CPPS. Everybody comes to me with these 4 letters. In my world, CPPS is pelvic floor dysfunction. I know. Because CPPS means chronic pelvic pain syndrome, right? Where's it coming from? I don't know. Do you? I don't know. Do your doctors? I don't know. But we do figure it out. It takes layers. A human being is like an onion, right? Or a cabbage. So you have to peel the layer. Some layers don't want to be peeled because once they peel, there's something else inside of it. So we have to go gentle. Some layers will peel off so quickly that you and I will be so amazed. But let's talk about this chronic pelvic pain syndrome. Pain could be anywhere. Of course, it depends on your gender. But you always have to ask, what causes pain? What controls pain? So I have to tell you, I am always amazed of a human body because our brain is the center of the body, right? It controls everything from the top down. Brain loves us. Brain wants to protect us. So I went out and I got certified in therapeutic pain specialist. We studied brain. For 6 months, we studied brain because it's the brain that protects you and it's the brain that causes you pain. And of course, we hate pain, but why does the brain do it? It's because it's trying to protect you. There's a pattern that taught your brain that something happened and I need to protect you. But then when that dysfunction goes away, the brain is still protecting you. And then the brain is very interesting. If I hurt my finger, and this is zip code 11223, and it's been there chronically for over 3 months, the brain is very cautious and says, I kind of want to protect this zip code. So I'm going to go down to here, and this zip code is 11224. I'm just going to turn on this zip code because I'm afraid this is going to get worse. And then when this is on and this is on, that's all the brain concentrates on these 2 zip codes. So now these are constantly on and your brain is just thinking about it, and that's all you are obsessing about, right? All day, every day is just this pain. The brain goes, maybe I should go bigger. I'm gonna go and turn on this zip code in the wrist. But at the same time, I remember that Zarina, when she was a child, injured her shoulder. Maybe I should turn this zip code on because maybe this is causing her finger pain. So now we're starting to develop regional pain, right? So everybody knows that now if you have regional pain, that's not local. Now we have global pain, and what's doing it? Brain. So you have to go to a pelvic floor therapist who specializes in therapeutic pain that studied how to change the narrative in the brain to manipulate the brain to stop the pain patterns, right? In grad school, we learned pain and spasm cycle. It rotates, spasm, pain, and that's what the brain is doing. And no longer the brain is doing it, it's just cycling in your spinal cord because the brain already processed it and told those zip codes, just cycle this is your protection. How do you interrupt it? How do you stop that cycle? So you have to go we have 700 receptors of different kinds of receptors in our body. So are we doing temperature change, hot and cold? Are we doing frequency, like vibrations? Are we introducing electricity and changing intensity and frequency? So electrical stimulation or shockwave therapy of some sort, right? Or compression. We have to study all of these receptors and say, how do we take all of these pain receptors sticking out and the brain is just chewing through that? They actually absorb back into the body every 48 hours. So all these pain receptors are firing because the brain said so to protect you. Well, how do we replace these? Maybe with temperature receptors, mechanical receptors. This is what we do. We do temperature change. We do compression. We do stretch receptors, right? We do shockwave, where it's different receptors that are replacing the pain receptors. So now the brain is realizing, oh, I don't have to fire pain constantly because there's other stuff that I am occupied to do. Sometimes when a patient comes to me with pelvic floor pain in a penile head, in the shaft, in the testicles, one or the other testicle or both, perineal pain, rectal pain. Women come to me with vaginal pain and rectal pain, abdominal pain, an abdominal pain that actually travels, has a mind of its own. I know the brain is doing it. There potentially was a dysfunction, there might still be a dysfunction, but once I clear that out through looking at organs and connective tissue and maybe decongesting lymphatics, and when you clean up and peel all the layers of the cabbage, what's left? Brain. So now you know to take the patient to 95% recovery. I never promise 100%, but let's say 95. You have to address the brain and you have to change the narrative. So sometimes I have to be very tricky. So if you come to me with a left side dysfunction, right, of a pelvic floor, I have to treat the right side because I know the brain is not protecting the right side. So I can actually do a shockwave therapy to your right perineum. The brain is not going to retaliate and fire back, but now the brain is looking on the other side of the body and saying, oh, there's other side that exists and it's normal. I don't have to protect it, so why am I protecting this side? So see how creative you have to be? Also, brain loves diagonal. So if you have pain somewhere at the bottom of your body, go diagonal to the top. Go as far as possible, not to flare the patient. Sometimes you have to be very creative. If a patient has left lower abdominal pain, go across the body. Don't even do the shoulder. Go posteriorly. Tell the brain, I am so far away, but look how good this feels. And slowly creep diagonally towards the dysfunction. That's what changes the narrative. Also, pain for humans is fear. So I did my doctorate on, so the title of my doctorate was, does pain have gender? Men and women in 42 ways differ of how we interpret pain, recognize pain, analyze pain, process pain, and let it go. 42 different ways, just based on gender. So how can we possibly treat CPPS as a blank statement? This is what we're going to do. You have to know what the gender is. You have to know if your patient had trauma. You have to also think, when they go home, what's the setting? All of that plays. What do they do for a living? What ranking in birth are they? You know, older kids are very strict on themselves. They're type A personality. They're very organized and analytical. And second ones in command are not so much. You have to keep all of that in mind because that's all sitting inside that human's brain. So when it comes to CPPS, you have to be very educated in how brain interprets pain, how spine manipulates pain, where is it on the body, and then take all of these extra things in. And that's the only way you're going to be successful to 95% recovery.